Hi, this is Dr. Lynn McPherson back with another exciting episode of Did You Know? And this time we're talking about my favorite drug in the world, my girl, Methadone. I'm a professor at the University of Maryland in Baltimore and the program director of our online Master of Science in Palliative Care. So let's revisit our case here. We have JH, a 52-year-old man, admitted to hospice with end-stage colon cancer with meth to the spine, causing neuropathic pain. His prescriber has asked you to calculate an equivalent dose of methadone to what he's currently getting, hoping it could better target the neuropathic pain. His current regimen is long-acting morphine 30Q12 and short-acting morphine 5 milligrams for moderate pain or 10 milligrams for severe pain every 2 hours as needed. And he's using consistently about 30 milligrams a day. So how the heck do we go about doing this conversion to my favorite drug, methadone? Well, I think we have several considerations we have to take before we jump into doing the math. First is we have to evaluate, is the patient a good candidate for methadone? What's their risk status? For example, do they have a history of QTc prolongation? Do they have risk factors for the same, hypokalemia, hypomagnesemia, a congenital disorder, things like that? What's the patient's prognosis? If someone is very close to the end of the road, for example, if they'll probably be gone before we get to steady state, which is 4 or 5 days, I would think twice about doing a complete conversion. I may use methadone in an adjunctive role and just add a little methadone on top of their current regimen. So I do think that's a consideration. Their history of medication adherence. If you have a patient who likes to pretend they're a freelance pharmacist, perhaps methadone is not the drug for that patient. Of course, interacting medications, and I always start with the 3 A's, amiodarone, anti-infectives, or antidepressants. So thinking about the 3 A's, although there are many medications that interact with methadone, and their pain history. So is this medication likely to be effective for this patient? So what guidance do we have in dosing methadone? So we did publish a paper on the safe and appropriate use of methadone in hospice and palliative care, and these are the guidelines that we recommended in that paper. For an opioid naive patient, which includes anyone getting up to 59 milligrams a day of oral morphine equivalent, we say anywhere from 2 to 5, or if you really want to press it, up to 7.5 milligrams per day of methadone. But frankly, we prefer the 2 to 5. Obviously, if you're going to go with a low dose like 2 milligrams a day, which is like 1 milligram Q12, you're going to have to use the oral methadone solution because we only have a 5 and a 10 milligram tablet available to us. Again, consider the interacting meds, most particularly anti-infectives, so antibiotics, antivirals, antifungals, antidepressants, the SSRIs, the SNRIs, the TCAs, and amiodarone. Those are your 3 big customers that are enzyme inhibitors that you have to consider. But there are many, many, many other drug interactions with methadone. What about someone who's opioid tolerant? Well, we look at their OME and we look at their age. If they're on the 0 to 59 range of OME, we default to the opioid naive dosing I just shared with you. If they're between 60 and 199 OME and they're under 65 years old, we do a 10 to 1 conversion. If they're on greater than 200 milligrams a day and or over 65 years of age, we do a 20 to 1 conversion. Now, occasionally someone will be like just over the 60 milligram mark, which defaults to the 10 or 20 to 1. Maybe they're like on 65 milligrams a day of oral morphine, and we feel compelled to use the 20 to 1, but it ends up that that's going to be a lower number than if the patient were opioid naive. So you do have to use a little professional judgment here as well. So some other precautions here, when you start a dose of methadone, unless it's really a wacky situation, we try not to increase the dose before at least 4 or 5 days, maybe at day 3 if they're in an inpatient unit. Also, we do not increase the total daily dose of oral methadone by more than 5 milligrams a day in total until they get to about 30 milligrams a day total oral methadone, and then we can go up by 10 milligrams in total per day. When you're converting to methadone, no matter how much other opioid they were on, sometimes we get patients on 1 or 2,000 milligrams of oral morphine equivalent. We do not start higher than 30 to 40 milligrams of oral methadone a day as a starting dose, because some of that may be that the previous regimen was causing some hyperalgesia. So you don't want to give them full credit for that. And research has shown that this is a good starting point. So maybe in a home care patient, I would start at 10 milligrams 3 times a day. And if they're in an inpatient unit, unit and I really wanted to be a little more aggressive, maybe I would go 12.5 milligrams Q8, for example. Also, if someone is on one of those 3A drugs, one of the amiodarone or one of the antidepressants or anti-infectives we're worried about, I would reduce what I calculated by 25 to 30% if they were taking one of those inhibitors. And again, I'm going to assess the patient daily for at least every day for the first 5 days, maybe longer if they have some liver impairment, for example, after starting the methadone and after adjusting the dose. So back at the ranch with our poor guy who's sitting patiently waiting for a recommendation on his methadone, his total daily dose of oral morphine is 90 milligrams a day. He is under 65 years old. He's under 200 milligram OME, so it's a 10-to-1 conversion, which would be 9 milligrams of oral methadone a day. Well, that's a goofy number, so I'm going to be bold and hike it up to methadone 5 milligrams Q12, and I'll use morphine 10 milligrams every 2 hours as needed for additional pain. Well, I hope you've enjoyed this presentation of Did You Know about methadone. And before I let you go, one last thing that I think you should know. If you're interested in just one of our advanced graduate certificates in palliative care, such as clinical care, in-hospice and palliative care, psychosocial, spiritual, or leadership administration, the deadline for application is May 1st, and you would start classes June 1st. If you're interested in the entire master's degree in palliative care, where you can earn 2 graduate certificates along the way, the deadline is July 15th. Thank you so much.